So we've already done the vertebral augmentation approaches, which sets us a little bit ahead of the game. So we're going to talk a little bit about chicken, and we're going to talk about burning chicken. And this right here is the OsteoCool ablation device. And we're going to try this, and we're going to, the way that the chicken meat will heat up, and we'll demonstrate the burn that goes into the center of the vertebral body for osteolytic or osteoblastic mats. Works better for osteolytic mats, but this is a radiofrequency ablation, cooled radiofrequency ablation technique called OsteoCool. And so we will do this, and what I would like to do is go ahead and get this started while we demonstrate the Kyphon assist from Medtronic and the SpineJack from Stryker. And so I'll show, instead of showing various approaches, I'll show various techniques on, all of these are vertebral augmentations. So these are different types of vertebral augmentation. Instead of balloon, we have directional balloon, the Kyphon assist, and then we have the SpineJack, which is a titanium intra-body expandable device. And so we'll just go ahead and get started on that. Welcome.
Thank you.
So, rhyme your name.
William.
Yeah, William.
Price.
So William is a bad influence. I met him earlier. So he's had good conversation with some of the guys that we worked with together in the past. And we're going to put you to work. Is that all right?
Yes, sir.
All right. So we'll start off with a bilateral access needle. So these needles, one is a beveled, and you can tell it's a beveled needle because it has a tan-colored cannula, or handle rather, and there is a arrow that tells the direction of the distal tip of the needle. The cannula is beveled, and it has a single bevel at the end. This is two different size dimensions. And this one is a diamond tip, same configuration of the needle, tapered at the end, and then has a tri-bevel. So we'll go ahead and get started. We'll do a transpedicular approach on these. So let's picture here. Picture here. So I'm going to picture there. Good. Centimeter up, 2 centimeters out. I'm going to go ahead and start with the beveled needle. Grab that. Thank you. Picture. Okay. So we're going to give it a little tap there to put it in. And we're about the 10 o'clock and 2 o'clock position. I'm going to hand this over to you, William. And I'm going to ask you to take it down just close to the medial wall right there. And careful on the tap because it's probably some holes in that vertebral body. All right, just a couple of small taps. And let's turn it around 180 degrees just like we demonstrated earlier. A couple taps. Good. And let's leave it right there. Let's go ahead and, for economy of time, we'll go ahead and just start on the other side. Picture. Okay. And this is the diamond tip. So we'll go ahead and start typical transpedicular approach. Picture. I'm going to come up a little bit. Picture. Good. I'm going to come up just a little bit more, get out of that visible track that we have at the 3 o'clock position on that. That seems to me like a Ramo track. William, what do you think? A Ramo track.
What did you say?
Yeah, because it looks like he came in at the 3 o'clock position for
That's the track of Ramo.
At the BVN. So I'm going to try to go around that, and we're going to drive it in. We're going to aim a little bit inferior. Picture that, and let's go lateral, which is we're probably okay given the amount of the needle is sticking up out of the patient. We're probably equidistant inside. So you always have to look at what you see here outside the patient. We can tell the trajectories are equal. We can see there's about the same amount of needle outside of the patient. And here we go. So this we will drive a little bit. Let's go ahead and medialize that a little bit and drive it on in. Good. A little bit more. And on this one, I'm going to do a little trick. I'm going to pull this back to the posterior wall. Picture. Picture. And I'm going to get a trajectory that's more along the lines of the other needle. So why don't we do this? We'll take the drill now. And I'm going to have William drill out to within 3 to 5 millimeters of the anterior vertebral wall. Let's go live.
Live.
Good, it's right there. And we'll swap it out for the other side. And then it's balloon time. So I'm gonna give you this. Okay. You can probably just go ahead and take that off, and then we will insert the balloon. Picture that. Good. We'll advance them just a little bit. Okay, let's see. I'm going to push mine out just a little bit farther. Picture. Okay, let's get an AP shot before we inflate. So by the look of the trajectory, we should be okay in terms of medial-lateral orientation. And we're a little bit lateral on my side. So to be able to correct this, let's do this. I'm going to just take the balloon out. And I'm going to put the directional needle in. Let's go back lateral. And we're going to use the directional bevel of the needle. Grab me the mallet. And we're going to take it back to the posterior wall. And we're going to angle inferior and medial. Okay, we're having a little bit of technical difficulties.
Got a problem?
Okay, let's restart it. Yeah, restart. So as he does that, I'll show you the radiofrequency ablation. So this is the area of ablation. It's already started. We see the two needles in here, and we see the area of ablation within the vertebral body. So this is about the same distance as this red dot on the proximal portion of that. I'm going to show you a little bit of the toolology on this. So this is the Speed cement, and it comes in a little cartridge for delivery here. And this is high viscosity cement, though. So this is quick to dough, high viscosity cement. This is designed to hook on the proximal portion of the needle, the cannula, and the sleeve there. And this is the CDS device. And as we trigger this, cement will come out. It builds up pressure in a hydraulic type of environment. And you can see the cement start to come out. And the quick release, the quick stop, is the trigger here on the back. We can just trigger it and stop it. And so we're pretty good. So a CDS along with the Speed cement. This is the curette. So the curette is angled opposite the handle. So the curette is here longitudinally. You trigger it, and it goes up like this, opposite the handle. And this is designed to be placed so you can curette. It has built-in stops. So you can click it, and this is about 45 degrees. That's about 90 degrees, and it has two stops, and it's turned like this, and it has a torque limiter, so you can't torque it too much, and you'll potentially break it, and right here is a torque limiter. So this is a curette. All right, we're back on. Picture. We're back on maybe. Picture. All right, so we're going to get a nice angle, right? Picture. I think we were just following a previous track, and instead of drilling, I'm going to take this with the directional needle all the way out. I'm going to pull this balloon back so I don't actually hit that. Don't know that I will, but. So we'll take it all the way out. Instead of drilling, we will be able to put the balloon in and then take the cannula approximately over the top. Let's take an AP shot of that. Good, so that's much better. We see we've bent a little bit of the cannula, so we're gonna turn it 180 degrees like this, picture. And then I'm gonna put the balloon in and withdraw the outer cannula over the top of the balloon. Okay, picture that. Let's move it lateral. Let's go lateral. Okay, from the lateral view, you'll see the two balloons in place, and I'll put it down just a little bit, picture that, and employ this, picture. Okay, all right, shall we inflate?
Shall.
All right, picture that. Okay. Boom. All right, nothing like a broken balloon. So what happens, this is a good time to ask the question, if you do break your balloon, what happens? Will the patient, will it rupture? Picture that, Steve. Will it rupture and carnage, mayhem will ensue, the patient will die? What happens? Does anybody know? The answer is nothing, because we used to do venograms to see where the extravasation would happen. So go ahead and trigger that and pull it all the way back. And we'll pull the balloon out. Put the stylet back in this, and we're going to fill it with cement. Shoot that, see? Yeah, so we should be able to take it out. All right. So the only limitation whenever you break your balloon is that you have contrast in there. And so you won't be able to, here's your CDS, won't be able to see the cement through the contrast, but as you can see, the contrast is starting to dissipate, whereas the cement will not. And a live person with circulation dissipates a lot faster. So you can see the CDS system filling now. Keep going. We're going to fill that whole cavity before it gets into the interstices of the bone. Fire away. Good. Stop right there, and let's put it on the other side. And we'll swap this out. Picture. Picture. Okay, go ahead. All right, slowly. So it's pushing the contrast out. You can see it comes out and then kind of dissipates into the medullary bone, whereas the cement stays hard and dark, and you can start to tell the difference between the cement and the contrast. So that's typical. It's even easier to see in a live patient, but that's typical for what happens. A little bit more. And that is all the cement we have. Very nice. Okay, so I'll take this out, put the stylet back in. Looks very nice from a lateral view. What do you say we take an AP shot? Thank you. And it's a work of art. Between the pedicles, almost end plate to end plate, maybe could use a little bit more cement, osteoporotic, and larger vertebral body. Okay. We have about 1 minute, 23 seconds left to go on the osteocool ablation system. And I'm going to go ahead and start with the SpineJack. and we will demonstrate that. Wonderful, wonderful. Okay, so this is a transpeducular approach. We're just going to do the same thing. Picture here. So get you started on this one. Picture. Okay, and we're going to come in just a little bit flatter on these. All right. I'm going to medialize those as much as we can, okay? Yeah. Good. Sounds like we're in the vertebral body. We had a tone change in a picture, and it also is not quite as hard. Picture. Okay. Sorry. So I got it. No worries. Okay. Picture that, Steve. Okay. So notice these are a little bit more 9 o'clock and 3 o'clock than 10 o'clock and 2 o'clock, because we want the SpineJack, let's go lateral. We want the SpineJack to be up parallel against the end plates. It doesn't matter so much for a balloon, but if you have two end plates that are parallel, pushing up against the flat end plate, having those surfaces parallel give you better lifting force. I'm going to be a little asymmetric here, but that's okay. Let's move north. Yep. Okay. Picture. Okay. So I'm going to go ahead and put mine in. Picture. And we're going to medialize this a little bit. Okay. And we'll put the K-wires in at this point in time. And go ahead and try to put the K-wire on that one. I'll put it on here. Okay, we'll put them out to the anterior portion of the vertebral body. I'm going to advance them a little bit so we can kind of tell where the final resting place of the jack might be. Okay. Picture. Let's take an AP shot of that. It's very good. I think the trajectory will be good just based on the outside of the patient. But we want to see all of these are size matched, so they're all cannulated. They're all placed over the wire, the K-wire. And so if the position of these K-wires are good, the position of your SpineJacks will be good. Okay, good. So yeah, we're going to meet those almost in the middle. Picture that. Yes, very nice. Okay, so let's go back lateral and do some of our work there. And we'll windshield wiper this cannula out. I'm going to enlarge make an incision.
Both of them?
Yes, both of them. Okay. All right, and so this is a reamer. This looks like a drill, but it's fluted on the sides, it's self-tapping. It's size matched, and the sharp cutting sides will tell you it's more of a reamer than a drill. So we'll just put this over. William, I'm gonna let you drill all the way down. So picture that. You see the drill, and just drill it all the way to the distal portion of that vertebral body. That's okay, no problem. Picture. Yeah, just keep on coming all the way to the end of that wire tip. Good. I'm going to take over just for a little bit, and I'm going to take this out. And that one was slightly more medial than the other. And I'm going to take this a little bit more lateral as I advance. And you can put some torque to change the direction of this as long as you're advancing, because it has the side cutting capability. Okay, perfect. All right, so we're going to take this out, the drill. We'll wipe that off, and then we'll put the acrylic plug to preserve the patient's blood volume. Picture that. It's acrylic except for the distal tip. Oh, that's a new acrylic plug, so it's radio opaque all the way through. So we will take this and put it in the working channel and go ahead and do the same thing on this one over the wire. Okay, shoot that. Good. I'm going to say the wire's going forward a little bit, so I'm going to loosen up picture. Yeah, go ahead. Picture that. On this one, I want to back it up just a little bit. See if I can't picture that.
More medial.
A little more medial. Exactly, picture. Okay. And remember, you can change direction as long as you're advancing. Okay, so now it's time for the jacks. And one for you, one for me. And we'll put them in. These jacks are, this is a 5mm titanium 13 turns to deploy, 10 turns on the colored handle to loosen it up, and it deploys parallel with this handle here. So with the handle, it deploys parallel. So the end of the jack will be coming out like this, parallel to that. So we're going to take, why don't you put it in there, take the acrylic plug out, stabilize it, and then put the jack in. Yep. Good. And so, take a shot. It's very good. Looks very good. Let's take an AP shot first. And so these deploy parallel to the handle. So it doesn't matter whether the handle is turned like this or the handle is turned like this. The jack is a mirror image, so it doesn't matter where it's how it's deployed, just as long as it's deployed in the direction that you want to reduce. So up and down in the spine, or if it's scoliotic, you deploy in the direction of the vertebral body, not in the direction of the table. Pretty good. I'm gonna do like this picture. Good. And so we'll deploy like that. So let's go back lateral. All right, William, you ready?
Yes, sir.
We're going to deploy 2 or 3 turns, and we'll take a look. Yeah, it's 2 or 3 more turns. Okay, let's fire away, all the way out. It's ratcheted so you can stop at any point in time. You don't have to deploy fully. And as I mentioned, 13 turns of the butterfly handle. Complete deployment, and we have a hard stop in the end. Picture that. Very nice. And we'll go counterclockwise on the colored knob. And then when you loosen it up, you just take it like this. We'll snap of the wrist. Nope, yeah, there you go. Just leave the other hand out and just snap of the wrist. That worked out very well. Okay, let's put some cement in. Are you ready?
Yes, sir.
So I'm going to put cannula in the other side so we don't get cement coming through that. And this will form a horseshoe-shaped area of bone. So go ahead and deploy the cement. We'll hold this so it doesn't push back. Picture, go ahead. Looks very nice. So it fills the track left by the SpineJack first, and it should join to the other jack, the cavity created by the contralateral SpineJack. Okay. Picture. Oh. So this is starting to push the other stylet out. Okay, we're going to see how good William is here. We're going to inject cement blind and see what happens. What do you think? This is Striker HV, so this is high viscosity cement.
Take a couple minutes.
Yep. Let's go ahead and stick it down to right about here. So this is a 5/8. This is the big SpineJack. And it's green. These all are yellow, blue-green for 4.2, 5.0, and 5.8. And this is deployed. You can see it's deployed parallel with the handle. So you want to get this right under the end plate and deploy it. And once this is deployed, then this is, you unscrew this, take this off. And what you have left behind is the working channel. And you have this that will fit inside of the working channel here, the outer working channel. And if you can see the little area of aperture that's at the distal end of the cylinder right here, this is where the cement comes out. So that right there, so it comes out toward the anterior portion of that, and it will fill the track left by the jack, and then we'll fill around it. So we've just filled a vertebral body blind because of our malfunction of our C-arm. And of course, you wouldn't do this normally, but it seems to have worked out okay because of the high viscosity cement in the jack. Let's go around and take an AP shot. And as he does that, these skis are attached to the what looks like a scissor jack. And this is made out of one piece of laser cut titanium. So the question I get a lot is, will this break, and has it broken? You know, what are the problems with the jack when expanding it? It doesn't break and it won't break. It's a titanium alloy. And that, my friend, is beautiful. Okay. Shall we open it up to questions, comments?
Very nice, Doug. So you've demonstrated for us now a unipedicular approach with the balloon, bipedicular with the balloon, and now the SpineJack. Can you tell us when you use what?
So I like to use the jack whenever the reduction is maximum importance. So if you have a thoracolumbar junction fracture that's decreased in height 90%, I'll reach for the jack. So balloons help control cement very well. The Kyphon assist will help you direct that balloon and the deployment of the inflation. Sometimes if there's no compression at all, if the patient is in fairly significant pain, maybe just a vertebroplasty is okay. If there's otherwise no reason to help control your cement, if you're a good technician and you could put the cement in the vertebral body, maybe just a vertebroplasty is okay. But it has to do most with the anatomy of the fracture, the situation, the degree of compression as to what I reach for.
So how important do you think it is to know all of these different techniques?
Very, so there's not any one technique that I use for everything. So back whenever vertebroplasty was the only game in town, that was important, it was nice, and then came balloon kyphoplasty, and that was a real leap forward in the late 90s and 99. I did my first one in 99. And then implant technology, and so we're kind of seeing the whole evolution of this. We even with balloons, we started off with medium compliance balloons, and then we jumped into low compliance balloons that would keep its shape and be able to inflate up to. These are rated at 700 psi, but really, if you measure them, they'll easily go to 1,000, 1,200 psi without breaking. So, I mean, it's a continual evolution. The way we go from here on out, what do we need? Well, we need screw-assisted internal fixation, hooking the screw to the reduction and fixation in front to bridge the middle column. We would like the ability to work on traumatic fractures and to be able to put a tulip on the back of some of these screws and do a multi-level construct if necessary. We need more cements. It would be nice to have a quick-to-dough hydroxyapatite impregnated cement. We can make PTH cements. I mean, there's a lot of different things we can do that just haven't been done yet.
Awesome. And what did the SpineJack solve for? And can you tell us a little bit about the results of the SACOS trial?
So I'm going to ask Regan what the ASP on average sales price on the SpineJack is, because I frankly don't know. ASP.
ASP stands for average sales price.
Yeah, about $3,700. It is, the SACOS trial showed, in direct comparison to balloon kyphoplasty, it showed greater height reduction, less adjacent level fractures, and better pain relief. So one of the things we take home, we learn from this, is that we think that maybe the pain relief has to do with the elegant small tools that we put in. We're able to accomplish the fracture treatment, barely do any invasion at all. Well, the SpineJack is a larger system, as you've seen. This is 4, 6, and 8 gauge from big to small, respectively. But if you're putting in a 6-gauge system, and sometimes a 4-gauge system, you're getting better pain relief. Maybe there's more to pain relief than the tools that you use. Maybe it's the outcome and the fracture reduction. And also, this is the first time ever I've seen a trial that demonstrated less adjacent level fractures than the predicate, statistically significant less adjacent level fractures, because, as Beck says, the thing that causes fractures is the spinopelvic imbalance and the degree of osteoporosis. We can't do much about the osteoporosis, at least while we're treating the patient physically in the procedure room of the OR, but we certainly can handle the spinopelvic imbalance and reduce the fracture more. So, there's a lot of take-home points about the SACOS trial that were real learning points. It's the first time at this time, it was 36 years of vertebral augmentation, that I've ever seen superiority claims against the predicate.
Wonderful. Any questions from the audience? Gavin.
Can you talk a little bit about the incidence of adjacent level fractures after kyphoplasty and what would be normal expectations?
Yeah, the incidence of adjacent level fractures are the same or less than the incidence of adjacent level fractures if you don't do a kyphoplasty. So there's, a new article in JBJS came out that looked at the Pearl Diver database, and it's pretty definitive that there's really no difference between vertebroplasty and kyphoplasty, but this didn't have anything else besides those two techniques. But it was a less than the non-surgical management, and the only thing that really changed it was medication management. So it appears to be more of how you handle the underlying disorder, and if you're able to reduce the fracture adequately, more than just what you put in the vertebral body. Because there's great data by Roeder. Pat Warden says the residual kyphosis is much more important about the stress and strain in the adjacent level cortex than what you put in the vertebral body itself and the stiffness therein.
Excellent. Any other questions? All right, Dr. Beall, great job as always. Thank you. We'll take another short break and then we'll come back for radiofrequency ablation.